We're back. We're recording. Hello out there. All right, I'll try to get this expeditious. My wife already wants me home. It seems we haven't been at home together for the last 5 or 6 days. It's time. All right. Wrong one. So, let me begin. So, you might remember more or less, we talked a little bit about what pathogens are. So, this is very, when I say the word boilerplate, this is very basic information. It's more, unfortunately, it's more memorization than anything else and terminology. The virulence is a measure of nastiness. They call it a degree of pathogenicity. I mean, it's just how rapidly, how much it can hurt you, how easy it is to get, how difficult it is to get rid of. All of those are factors that we call virulence factors, and really distinguishes something like COVID from the common cold. How something is relatively innocuous, comes on, goes away, we're probably fine afterwards, versus something that could be potentially life threatening. And that's the difference. A lot of times it's not so easy for to identify one source. As we have gotten better understanding of infections, we're seeing a lot more of what we call polymicrobials. It isn't just a Staphylococcus aureus or a Streptococcus uh, pyogenes infection. It has many factors. It can involve multiple things. And they talk about here when they're starting to look at skin infections and finding a third item, which happens to be normal on our skin. Yeah, you may not have encountered, and we'll talk about that in respiratory. Moraxella, it's a little gram-negative coccus that is around all the time. We never thought it was of any consequence. Perhaps studies now are pointing to this. Okay, so a lot of times it'll be more than once. Typically, the flu doesn't kill people. What kills people is bacterial pneumonia after the flu. Is there a linkage or anything like that? So, do you want to be over by the window? I'm sincerely, I'm not, you know, being trying to be cute. Portal of entry is very much unique to each one that we look at, but we group them together. Ones that we inhale, just like how that viruses are spread. And so they're very similar with respiratory or fecal to oral. And even though the terminology is a little bit different, that's another way that we have to look at potential virulence factors. So how and inevitably it's how it typically gets in. There are oddballs that are there. I mean, you could conceivably get a nasty infection if you had an open sore and somebody was bleeding and it was in their bloodstream. So that's not necessarily the way it would typically be spread. I mean, conceivably that could happen. That's pretty rare. And as I said to the other class, for many of you who are going into the healthcare tree in some way, shape, or form, be very aware of any open cuts or sores to make sure they're covered, or be wearing gloves. Nowadays, that's commonly accepted. People kind of go a little nuts. I don't know if you've seen it or you do it yourself, but somebody comes at you without a pair of gloves on, because we didn't wear gloves until about 1994 routinely for most things. We didn't wear them in the emergency room in the late 70s or anything like that. But it protects you and it protects them. When I was a resident and operating, we had hand inspection. Before, if you were on a surgical unit, the chief of surgery would look at you and go, before he assign you to a case, go, let me see your hands. I mean, you were at a risk to yourself if you had an open wound, even with gloves on, and you were a risk to the patient because it was easier to spread. It's just so down the road, if there's an underlying thing for this particular presentation, hand care, hand care, hand care, hand care. Be cognizant. Don't overdo this stuff, because little abrasions you can't see are a problem. And yeah, we can have things that are from inside of us. Okay, when you burst an appendix, it's an endogenous entry. It means those are already in your gut and they get into your system. We're already harboring, versus exogenous, typically what we think of, we're in a room and somebody's coughing or sneezing, we pick up a virus or something along that's outside of the body from a definitional standpoint. And it's interesting that they typically over time, whether it's viruses, which are not technically organisms, or bacteria, which are, they adapt over time. they modify, they mutate for them to flourish. Like any, if you want to take it to the point of being a species, even for the viruses, which are not by definition, you know, they're going to find a more and ways to invade or occupy a more favorable habitat. So it's unlikely, but you can indirectly have a problem. So this is even a flu virus you have to inhale. But I was telling the other class is if somebody, you have no idea who's in this room before you. And if somebody's sneezing and coughing, probably shouldn't have been in class, and it gets on the table and before it becomes inactive, you touch it and get it on your hands, it'll stay active on there. And again, you touch your face 5,000 to 8,000 times a day. I mean, I can look across the room and at least 3 of you will be touching your face or have your hands on your face like you just did or you have over there. Russ. Okay? So it's easy to spread. And you can't be going over to that thing every 2 seconds. That's kind of when we were only allowed to have like 10 people in this room when we were back in during COVID. Maybe your schools were like it the same way. So scientifically, you should not get the infection. It doesn't mean you cannot if the circumstances are right. So you may not, I mean, TB is respiratory and TB stays in the air all the time. Okay. It's odd, but it can also enter through the GI tract. That is certainly an oddball for its particular passage that are there. And we see Staphylococcus, which I call for all the world public enemy #1, and Streptococcus are by far and away the most, 95% of skin infections, a lot of urogenital, a ton of respiratory infections that are all in here. So they aren't confined to one area. So they have different systems they can infect, and usually there's some subtle differences with them. So for instance, I mean, here's the staph and strep. I'm not giving you the formal names, we'll get there. Staphylococcus aureus and Streptococcus pyogenes, tetanus. You get tetanus, yeah, I stepped on the nail or whatever, you're from a bad wound, but the endospores are in the soil, but it's everywhere. Again, you're tracking in the carpet just from coming in outside. And so therefore it gets on your shoes. Maybe you took off your shoes in class, they were hurt, now it's on your sock. Doesn't take long. Okay, we see all of that. So herpes simplex is not really skin, it's mucous membrane. So again, sometimes PowerPoints have incorrections. I don't know enough about worms, but they do go through the skin. And a ton through insect bites. We've had an odd winter that's turning into an early spring season. And as it gets warmer and wetter, one thing is true, we get insects. So this is the time of year we have to be more cognizant of that. And there are a lot of areas, even around here, where mosquitoes can flourish. Standing water, somebody who doesn't keep up a pool that's uncovered, got a lot of green stuff on it. That's where mosquitoes breed. That's where ticks breed. And we have a ton of it around here, a ton. So, you know, you have to be aware of wherever you are. And then it's through the conjunctiva. Here's the GI stuff. There's so many of these. Eating and drinking contaminated foods or fluids. And here's an important word of the day. Okay. Magic word is fomite. What is a fomite? A fomite is an animate object. It's the straw that you are using with your McDonald's cup. Where is my Shamrock Shake? Okay. A straw is this. Hey, can I use your cell phone? It's a fomite. Then you can pass to somebody else. It's your keys. It's, God forbid, you use the water fountain. Ugh. Okay. Stay away from water fountains. They are fomites that have all sorts of bad stuff on them. And a lot of times we'll talk about how things spread directly or indirectly. Indirectly, I'm coughing. I touch the table. The table is a fomite, an inanimate object. You touch the table, touch your face. You got the idea. Okay. Inhaling a zillion different ones. Urogenital, a zillion different ones. And it doesn't have to be a broken surface. Damage only accelerates the process. When we start talking about urinary tract infections and related structures, if they're damaged, it's really a problem. Okay, but they don't have to be damaged to be a problem. And we'll talk about, I mean, something like gonorrhea, it doesn't have any damage at all. It attaches to literally anything. Okay. This is a big player. I mentioned this in passing at the end last time. Infectious dose. Low infectious doses, big problems. Okay. The smaller the dose, the nastier it typically is. I don't know a lot about Q fever, but I know a whole lot about these three. Only 10 cells. And I told you, tuberculosis is in the air. If you're in a hospital and they have a known TB with active TB patient, every time they cough, and it's all they do, out go tuberculosis bacilli. They say they are airborne, which means they don't drop to the ground, they stay in the air. They're in a hospital room. That room has an exhaust fan with a filter pulling that out. You have to wear personal protective equipment, whatever it is. It's one of those N95 masks. I don't know what they use today. They used to measure nursing students for that, for TB patients. I don't know whether they do it now. That's their job, not mine. Giardiasis, contaminated well water. My kids had that. They were staying with my office manager. I was out studying for a conference. I had to go to a seminar. And my first wife and I both went. They all got that. Thankfully, not terrible, but diarrhea for 3 weeks. Ugh. Coccidiomycosis, I mentioned that in passing. That's the disease it causes called valley fever, formerly called San Joaquin Valley fever. You want to go have a nice little desert vacation, go to Arizona, go to Southern California, go to Palm Springs, those areas everywhere. Animals can get it, you can get it. We're very aware of it. Again, it's airborne. These are fungal particles that are easily inhaled, and it's all about the numbers. The more you have, the less your defenses can fight off. My brother-in-law and his family are all in Tucson. He had a dog die of valley fever. He's one of these, he'll hike everywhere. My wife calls him Psycho Bob because all he does, he has the identical shape. He's my age, and there's no fat on him at all. It's not ex-Air Force. Very fit. Gonorrhea. I just mentioned that. 1,000 cells is not a lot. If you had a tiny droplet of culture media, you'd have more. You'd have 10,000, 100,000, 1 million cells easily in that. And so we don't see as much of it now because we're a bit more aware, and it's something we're more readily and have easier ways to treat. And there's a lot less stigma, and we use condoms and barriers much more commonly. When I was a resident between 77 and 79 in the inner city hospital emergency room, I have 10, 20 cases a day, nothing. Everywhere. Gonorrhea and syphilis, everywhere. We'll get to that at UTIs. Typhoid is salmonella. I had that. Doesn't take much. Cholera, devastating to areas where, and that may seem like if you're looking at this, a billion cells, your culture plate in the lab has 1 billion cells easy. This is contaminated water from natural disasters, war-torn countries, floods, it's common. It's a horrible disease. The big deal, in order for them to affect you, they have to attach. Okay? And that's the instance with the gonorrhea. It has a lot of fimbriae that easily, extraordinarily easily, attach to almost all types of cells. And again, we'll go over that. So they're relatively easy, so their ability to adhere makes them unusually more virulent or a significant virulence factor. Okay, normally it has to do with sort of like they have to have the specific one on the pathogen and one on the host. And that limits what we describe in this unit as the range, the different number of cells or areas or species it can get to. And it's got to be firm because we have a lot of things. We cough, we sneeze, we urinate, we defecate. It gets rid of stuff all the time. We wash our hands. With doing all that stuff, basically limits things that don't have a firm attachment. It's like, if you're going, we all do that. We go someplace, our hands inadvertently get dirty. What do? We go in and wash our hands. So we do it before there's a, we're already alert to the possibility of the problem. Let's see. So moving on. So this is the one I was telling you with gonorrhea, and we talked about this in bacteria, those little bristles. E. coli does the same thing in your gut. It doesn't take much to adhere. It's rather easy to do that. And so, and even we see adherence, a lot of these bacteria are in groups and they form those slime layers. Those adhere that are there. Viruses, talked about the protein spikes. Again, I don't know, and I'm not going to ask you about worms, but just seeing suckers, hooks, and barbs troubles me. Which reminds me, I'm taking these are folks who just had the test and are a late arriving crowd. You're fine, no problem. You all look rather somber. What we like to call unhappy campers. I like that. See, then you're not mad at me. See, if you're mad at somebody else, it's not me. Okay, now, this is something that's really interesting. Basically, and I'm sure you talked about it in AP1. I know you guys didn't do the immune system yet. Many of you are the ones who had me for AP2 previously. Phagocytosis. We basically swallow our problems. It's a wonderful thing that we do. We identify them, we immobilize them, and we gobble them up. Bacteria, viruses, for the most part. And again, it's when they're overwhelming us in numbers is the problem. That's the good news. The bad news is a lot of these entities have mechanisms that destroy those white blood cells. They have that slime layer or capsule that they can't penetrate. And in the case of, and this is the third time we're mentioning it, tuberculosis, not only is it almost impossible to swallow, if it does, it actually lives inside the macrophage. If you did not know it, and we do a fairly substantial, 15-minute or 20-minute presentation on TB, they grow and flourish inside a white blood cell, so your body doesn't know it at first. And a whole bunch of them grow when your body gets the idea it's there. It surrounds it with white blood cells. It's too late. They grow inside. They cause damage inside this giant cluster. And finally, they cause this thing we call a tubercle, how it gets its name, to burst, and then it can spread anywhere in your body. The way I frame tuberculosis is a bacterial disease that spreads like cancer. That's a pretty significant description. It can infect bone, it can affect your heart, it can go to your liver, your lungs, your kidneys, just like a terrible cancer. So it's hardly innocent. So they have a lot of different ways once they're there. So they may be inside of a cell or they may be on top of a cell. Your immune system, when you get to immunology and the immune system, when they're outside of a cell, we respond to it. They're not going into it in length with antibodies. When they are inside of the cell, we use what are called T cell or cell mediated ways. So we go, rather than destroy it on the outside or what it does, in the inside, we have to destroy the cell that it's in. Would be the way to describe that. So once they're there, once they set up shop inside or outside, then here's some of the problems. Most of them is enzymes or toxins. We talked about endotoxins for gram negatives only and exotoxins for both. And a lot of them secrete chemicals that in their wake do damage that are there. That's what enzymes do. And they're going to characterize a few of these. So understand that this is there's a lot of different ways they cause harm to it because it can do just about anything. Toxins themselves. A way that you don't think about as much, but is really as dangerous and perhaps more so than any. If you have a strep throat, the thing you're worried about your throat's going to get better, I promise you. The thing you have to worry about is your own defenses. It causes your immune system to either activate inappropriately or go crazy. If it goes crazy, it does things like scarlet fever. Okay, it does things like toxic shock syndrome. It does really nasty stuff. Okay, if it causes your immune system to react inappropriately, it does something called rheumatic fever. Okay, or it can shut down your kidneys. That's all. And so it's not a toxin. It's your body's response. It's your response. And there's nothing you can do about it unless you get rid of the bacteria. That's why moms forever, when we get to strep throat, that was one of the few things that got you to the doctor. If you had stinky breath because it's anaerobic in nature and a red throat, that might get you to the doctor. Everything else, you're going to school. It's okay. So we all tried it, but we weren't successful. Moms were pretty sharp in those days. Okay. So that's the host defenses. And even it's interesting that to prevent the effectiveness of your own immune system, it'll actually make subtle changes in your cells that make it seem like everything's okay. That's what epigenetic changes. Hey, there's nothing wrong with this cell, go elsewhere. That's pretty clever for just a bacteria. So they're just showing it to you, and there's not a lot else to say about that. These are some of the enzymes that, and when it says exoenzymes, it means they're spitting them out. And what they do is they inflict damage on tissues. And so they can if your body tries to wall off the infection, they can cause it to break through and spread. So just some examples. Mucus is a big protector. It traps that stuff. What happens if you destroy the mucus? It spreads easily. Mucinase. Hyaluronidase. You go back to AP1, and you go back to connective tissue, part of that ground substance in our connective tissue, loose areolar, adipose, dense regular, dense irregular, blah, 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 all that, all those connective tissues. What's interesting about them is the ground substance that the fibers are embedded in them. One of the big components is hyaluronic acid. If you break through it, spreads through the tissue. So we call those spreading factors. Our old friend Streptococcus, I mentioned, with all that other nasty stuff, it's got a bunch of those. So there's a number of diseases that are highlighted by streptococcal infections. And one of the things that they do is they spread. You'll see redness, not just in a line, but all over. It's really a very, very interesting thing that we see with regard to that. I don't know whether you test for it in lab. It's called coagulase. When I was in practice, when we had a staphylococcal infection, they didn't say aureus or epidermis or albicans. It was coag positive and coag negative. Coagulase would stop your white blood cells from getting to the party. That's one of the major virulence factors of Staphylococcus aureus. And it's one of the ways you can distinguish it in the lab, whether you do the test or not. I used to do it kind of pricey to do that. And then lastly, kinases and dissolving clots. Well, what happens with clots are your body's attempt again to wall off the infection because you're damaging tissue and tiny capillaries and blood vessels. And I drew this before. It's effectively a clot buster. But Streptococcus made it was called streptokinase. It was so powerful in dissolving clots that we used to take it from bacteria and inject it by catheter to dissolve clots in a recent heart attack, a very recent, a new heart attack, new stroke. We stopped doing that because a lot of people had adverse responses, hard to control. We did not know it, and I asked the other group, and they weren't, maybe you learned about it, maybe you didn't. It's called plasminogen. Your body makes clots all the time. And what your body does about 48 hours after you form a clot, because if you didn't, your blood clots constantly in your blood vessels. All those Rover hairs in your your blood vessels. If you don't get rid of those clots, vessels will be all clotted up. So your body starts to dissolve them. And what it does is it makes this TPA, tissue plasminogen activate. We make that now genetically because it does the same thing streptokinase. So if somebody has had a recent stroke that they just came to the emergency room and they just had it that day, they'll try to feed a catheter up and put it intravenously to bust clots. So what that does is it changes a protein in our bloodstream, plasminogen, to plasmin, and that's the clot buster. So that's part of the clotting cascade. You did the blood unit, but not everybody does that part of it. But it's very interesting. So that's one of those interesting genetically modified products like human insulin and human growth hormone that we make, okay, because of microbiology. Toxins. Those, and these are, we're talking about exotoxins. Endotoxins cause something. They cause basically a dramatic response by your immune system. Endotoxins, when they get into your system from a ruptured appendix or a burst bowel or a burst ovary or something like that, or a tube, those are the kinds of things that everything goes crazy because your body responds very aggressively with an outpouring of chemicals from your immune system that dilate blood vessels, and all of a sudden you're not getting blood flow to important areas. The name for it is gram-negative sepsis or endotoxic shock. All those chemicals dilate blood vessels, and blood's not getting to your heart, not getting to your kidneys, got to get to your brain, your lungs, where your body tries to compensate. Your pulse gets very rapid, your blood pressure drops precipitously, and you're in big trouble. That's not reversed right away. Your kidneys will start to fail. And I am a very good authority on that because I had something very much like that put me in ICU about 18 years ago. So more on that down the road. So exotoxins work on different systems. So they can do those passageways that nerves use to basically make and transport neurotransmitters, which you learned about a lot in AP1, okay? Basically, they're called neurofibrils, neural passageways, and they carry stuff out to be secreted and carry stuff back being to be sort of recycled. So it's a two-way street. Nerves only fire in one direction, but they carry materials back and forth. Bad guys hijack them. So there are neurotoxins. Enterotoxins, that's a classic toxin for food poisoning. Most food poisoning is just that. It's a toxin that you ingested. Food spoiled. It started to produce spoilage, meant bacteria made toxins. You ingest the toxins, okay? And they can affect you. Chemotoxins break apart red blood cells. Nephrotoxins directly damage kidneys by a variety of mechanisms. They'll show you some of those that are there. So just for context, neurotoxins, even though you ingest botulism toxin with botulism in foods, it enters your bloodstream, rapidly gets into the nervous system, paralyzes muscle. Tetanus toxin, same thing, though it comes through a wound. Once the wound gets infected with tetanus, the tetanus toxin goes through your bloodstream and effectively paralyzes you, although differently than Botox. So neurotoxins, what the watchword of them is, they are very, very rapid. I'll cite you two examples of those. So for any of you who live here, one of the things you have to learn about, particularly depending on where you live, or if you're in a population, is what are venomous snakes? The continental United States, there are 4. What's here in Pennsylvania? 2 types: rattlesnake, copperhead. Which one is more dangerous? Copperhead, because it's a neurotoxin. Okay, much more dangerous as opposed to rattlesnakes, where you actually have a little wiggle room if you get a tourniquet on there. maybe cut it to let some of the stuff ooze out and get help. As opposed, and most of the time, when somebody comes in an area where there's a lot of snake bites, hospital have what are called polyvalent antivenom. It's an antivenom for a lot of different snakes all rolled up into one that are there. And so the other hemotoxin is down typically in swampier areas. That's the water moccasin, which is a particularly unpleasant snake. That's an aggressive snake, if you did not know. And the one that is the most, looks most innocuous, but perhaps is the most deadly, is the coral snake, which is in the desert Southwest, which looks like a little bracelet, but has a very potent neurotoxin. You remember the whole idea about Cleopatra and the asp? Yeah. So she put it to her breast and died because, Mark Antony, she had died and she was being invaded and she was going to be brought as a hostage to Rome. So in that famous story, the asp was really a baby cobra. Cobras are neurotoxins. A little snake lore. I have a binding non-aggression policy with snakes. Same with bears, by the way. I don't bother them. I don't expect them to bother me. We go on our own.
And if you sleep with it's not.
I don't sleep with snakes. My idea of roughing it is going to a hotel that doesn't have room service or a hot tub in the room. My wife is a camper. I know. The dog and I, we're going to go camp.
They go by themselves?
Oh, yeah.
What?
What? Not this bad boy. I'll make all the food. I will take it over there.
Yeah, do you like glamping?
No, I don't even like camping, even glamp camping. We were going to do that the COVID summer. We had a glamp reservation up in Michigan. So she's adamant that we're camping this summer. And you remember how I deal with that when she tells me, we're going camping. I look her right in the eye and go, yes, dear. I got it covered. Yes, dear. We're going. Okay. This is the idea of endotoxins. And all of this comes from the immune response that causes dilated blood vessels, opens the blood vessels for stuff to escape. That's the hemorrhage. An offshoot of the immune system is diarrhea because everything tends to accelerate through the gut. And a lot of these are part of this. And these are particularly fatal. The one that put me in ICU was salmonella. I'll give you that story down the road when we talk a little bit more about that rather than today. But all of these have extraordinarily bad ramifications that are there. And they have a little chart about this. And then, and I think we're about done. Yeah, I do signs and symptoms, then we're done. Is we categorize infections by, if you get a little pustule, if you cut yourself and it's a little dry, it goes away, that's localized. An isolated case of athlete's foot, typically localized, doesn't spread. Where systemic all through your body. And typically by the bloodstream, it can be by the lymph and it can travel. All those types of things. These are an interesting offshoot. Periodontal disease is more common than you think as people get older, and it's polymicrobial. The problem with that is it damages your gums, and all those microbes can get in. Every time you get your teeth cleaned or scaled, if you brush your teeth vigorously, sometimes even if you eat, you get what's called a transient bacteremia. There's so much blood flow in and around, blood supply in your mouth. That's why you can give medicines sublingually. And that's how a lot of diabetics will take sugar in if their sugar starts to bottom out. So you got to be careful with that. Here, a periodontal infection can lead to conceivably heart disease. My mom had 3 periodontal surgeries as she got older that were quite extensive. And when I say older, she's probably not yet 70, maybe just around 70 years old when she had it in. Her stated aim was until she died, was to keep her hair and her teeth, which she did. She said, I will spend all my fortune to do that. Atta girl. So, I mean, we do see a lot of these polymicrobial ones. We're going to talk about bite wounds down the road. We'll talk about gastric. Human bite wounds are far worse than animal bite wounds. Far worse. I mean, I'm just telling you. And again, I talked about this in the flu. The primary infection could be anything. The damage it caused that allows another infection, whether it's pneumonia or an ear infection, secondary. And then we look at acute versus chronic, which we covered. And the last topic for today, and that's where I finished the other group, signs and symptoms. I'll do syndrome first. A syndrome is a compilation of signs and symptoms. Diabetes is a syndrome. AIDS, by definition, acquired immune deficiency syndrome. You have a weakened immune system, you're prone to infections, you can succumb to the infections. It can occur anywhere. Diabetes, you can have, sometimes your kidneys will be fine, sometimes it'll be awful, sometimes your sugar will be relatively stable but high, sometimes it'll be very labile. But you'll have certain things, typically hyperglycemia, frequency of urination, etc., etc. Those kinds of things, that's why we call it a syndrome. There's nothing you can bank on that's a giveaway for it. The difference between a sign and a symptom. A sign is observable or measurable. If you say you have a patient who comes, I really feel terrible, I think I have a fever, that's a symptom. A sign, take their temperature. If they're febrile, if it's above normal, whatever the number is, that makes it a sign. Blood pressure. Okay, I feel like my head's going to explode. You take their blood pressure, it's normal. You take it and it's 200 over 100, that's a sign. So observable or measurable. I'm nauseous, it's a symptom. You see somebody vomiting, it's a sign. It hurts all over. What happened? I fell on my elbow. Oh, really? And you go squeeze it. Now, if they're telling you it hurts everywhere here, when you squeeze it, that's called pain on palpation. And they jump. That's a sign. Difference between a sign and a symptom. You must know that. Typically in a chart, unless they've changed it, I don't know. I haven't written a hospital chart in over 20 years. We do the subjective first, chief complaint, how the person is feeling when you do an evaluation. Then you do objective findings, tests, measurement, blood pressure, pulse, vital signs. Are they bleeding? Is the wound healing? Then the assessment, then the plan of action, and maybe there'll be more. That's typical. That was the old style we called SOAP, subjective, objective assessment plan charting. Maybe they do it differently. Those are the important parts. And I'm going to stop here and we're going to go from there. We'll come back from break. So like that, now we'll get more into what's going on after that. Thank you once again. Have a great time away from break.